We are about to start this first session in this wonderful congress. My name is María. I'm a pediatric palliative care nurse from Madrid. And first of all, I would like to thank the Maruzza Foundation for this wonderful congress. It's been very inspiring and enriching. It's great to meet people from other countries who to share experiences and information with. So, I don't know how this works, sorry. Today, I'm here to talk about the telephonic consultation in home care emergencies. So I hope my presentation will come up, otherwise. Here we are, great. Let me just check, okay. So, as I said, I work in the Comprehensive Pediatric Palliative Care Unit of Hospital Universitario Infantil Niño Jesús in Madrid. And today, I'm going to talk a little bit about literature. Then I will talk about some general aspects regarding telephone consultation. And finally, I will move on to urgent management of management or urgent situation by telephone at home. So, to start with, I would like to say that, as we all know, telephone consultation has shown to be really, really useful in different healthcare fields. And I did a literature search, just a very small one, while I was preparing this presentation. And as you can see in the slide, the scientific output regarding telephonic consultation in healthcare started to increase in the 90s, reaching its peak during the COVID pandemic, because as we all know, during this period, this type of consultation became crucial. In pediatrics, this is also an explored topic. However, the scientific output started to rise a bit later, around 2014, 2015, but as well as the other search, it peaked as well during the COVID pandemic. In pediatrics, telephone consultation is of great value in different fields, such as dermatology, nutrition, surgery, and some authors pointed out that it's very useful in order to follow up between face-to-face visits, early initiation of treatments, usefulness in determining when a face-to-face consultation is necessary, and also they raised the possibility of offering medical advice in remote areas, which is of great importance in those countries with a significant geographical dispersion. I also looked for telephone consultation in pediatric palliative care and for home emergencies in pediatric palliative care. However, although I obtained a few studies, when I look in depth into them, none of them talk about how actually they deliver that type of consultation. So my unit was created nearly 17 years ago, and since the beginning, we've been using telephonic consultation. This is a very useful and important tool for all of us. So I would like to spend the next two slides talking about how do we work and how are we organized, because I think it's important in order to understand how do we manage home emergencies by telephone. So, my unit has the different facilities. We have a pediatric palliative care ward, we have a day hospital, an outpatient clinic, and also a home care unit. And we deliver the care into 3 different levels. So we have around 600 patients in level 1. These patients are only followed in the outpatient clinic. Then we have around 20 that are under home care program from Monday to Friday, from 8 o'clock in the morning until 15 hours. And then we have around 90 patients that are hospitalized at home, and therefore we offer them 24-hour care 7 days a week. And these are the ones that actually contact for home emergencies. The type of patients that we have are mainly patients with a neurological condition. However, we also have oncological patients. So maybe you know, but for those that don't know, Madrid is not the biggest autonomous community of Spain. However, the farthest point from the hospital is 100 kilometers away, and we are the reference unit for the whole community of Madrid. So, in order to deliver the care, we have divided the autonomous community of Madrid in 4 different areas, with 1 team allocated to each area. Each team consists of a nurse, a doctor, a psychologist, a social worker. And also they have a shared spiritual advisor, pharmacist, physiotherapist, and healthcare assistant. So in the first visit, we explain them how do we work and how we're going to deliver the care. And we tell them that we will do program visits and urgent visits when needed. So in between that, we tell them that we will also do a telephonic consultation. In order to achieve this, because we also tell them that they can call us too whenever they need it, we facilitate 3 telephone numbers. We facilitate the reference team telephone number that is available from Monday to Friday, from 8 o'clock in the morning until 3 in the afternoon, and they should call within this time for any reason, doesn't matter if it's urgent or not. And then outside this schedule, we have the nurse on-call telephone number and the doctor on-call telephone number. Another important thing regarding emergencies at home is that we tell them that we don't travel by ambulance, we travel by car. So, because I said previously, the farthest house is 100 kilometers from the hospital, but sometimes we are in the south of Madrid and we have to go to the very north. So, or maybe a simple thing and there is lots of traffic. So we tell them that it can take us up to an hour and a half to reach their house. However, we assure them that during this time, we will be giving them telephonic support. So in our case, we have 5 different types of telephone calls. Some of them are made by the nurse, others are made by the patient or families. The nurse do the home care planning calls 24 hours prior our visit, just to check the availability of the family and to make sure that they are going to be at home. And also, doctors and nurses do program calls in order to do follow-up, symptom management, family support, and also families call us too. Families and patients, yeah, because we have also adolescents or young adults that they call us by themselves. So this type of calls could be because a non-urgent matter, such as a care concern or a problem with the medication, or an urgent matter, for example, acute symptom, a situation worsening, or a problem with a device. Also, we have internal calls. This is very, very important to ensure continuity of care. And we have internal calls between the nurse on call and the doctor on call. Also, there is another type of call that I haven't put in there, and it's because, as I said previously, we are the reference team for the whole community of Madrid, so therefore other hospitals call us also during urgent situation regarding some of the patients that we see in our outpatient clinic, or patients that we have not seen yet, but maybe they are going to transfer us, and maybe they call us in order to do symptom management or to ask for advice for different type of care. But when it comes to calls, what do you think is better? Telephone call or video call? From our experience, both. Because video call complements telephone interviews. And we find it very useful for assessing the child's condition. For example, when a respiratory distress or when it's having seizures and maybe family cannot detect if it's a seizure or not a seizure, sometimes we tell them, okay, don't worry, call us when this is happening. Also, it's very useful to guide and address families' questions regarding different techniques. For example, if they have problems administering drugs or with the oxygen therapy or whatever. and also to detect problems with any of the devices, the oxygen tank, the suction machine, and sometimes those problems can be sorted out without the need of actually going to do a face-to-face visit. And last but not least, lots of family finds really, really helpful to actually see us, even though we are not there. So the video call also allow us to give lots of emotional support. So now I'm going to start talking about how do we manage this situation by telephone. But what type of situation do we manage by telephone? Well, all of these. These are the common ones. Sometimes could be others appear, but this is the common one. Respiratory distress, pain, seizures, irritability or agitation, hemorrhage, fever, nausea and vomiting, constipation, oliguria, device-related problem, and severe deterioration or even death. But how do we do this? For us, one of the most important things is to keep all the entire team informed. So in order to achieve this, and for us to know about all the patients that we have hospitalized at home, we do informative brief team meetings twice a day. So we start the shift with a team meeting in order to know what happened during the on-call shift. And then at 2:30, we finish the shift with another team meeting in order to know which patient we have visited today, how are they, if any patient is maybe not as well as before, and maybe we have to go and visit him or her during the on-call shift. And also we do a long weekly team meeting on Wednesday where we talk about advanced care planning, complex situation, or new admission into the hospitalized program. Another important aspect to deliver this type of care is to provide families devices and drugs in advance as a just and in case measure, because if someone calls us in an emergency situation and it can take us up to an hour and a half to reach their house, and we don't have anything at home for families to start treating and helping the child, at the end of the day, that call is not useful. So what we do is that we do an individual assessment of his child about his or her risks and potential complications. Regarding this, we provide an oxygen tank, suction machine, pulse oximeter, and even some drugs, for example, oral morphine or oral midazolam. Obviously, this is under a very strict control by the pharmacy of the hospital and the nurse, and the referent nurse of the team. Also, we have a drug chart in the houses because it's very important that patients are fully aware about the doses and the medication that they have to administer, because they know by heart what their son or relative have as daily treatment. But when you go on to on-demand medication, it's important also to have that very clarified. So we update this drug chart in every daily routine visit. Another important aspect is that families should know how to contact us, because when they first arrive into our team, they have never received previously this type of attention. So they get a bit messed with all the numbers. So sometimes they may call the reference team, but they should have called the on-call team. At the end, if we don't answer, they will move to the next contact. But it's important for us that they call straight away to the right one. So this is something that we work also in the home visits. And to me, the essential one is good communication. Not only among the team, among the on-call professionals, but also with families. And for this, we need to have good communication skills, because when family is facing an urgent situation, they may feel nervous, they may feel scared, and we have to be able to actually take all the information from them to know what's happening in the house and to give clear recommendation for them to follow. So who and where? As I was saying previously, families are informed when they should call the nurse and they should call the doctor. So we do like easy example. Like for example, if it's a device problem, you call the nurse. If it's a fever, you call the nurse. But for example, if it's an acute symptom that hasn't appeared before, you call the doctor. Anyway, there's no wrong choice here, because if they call the doctor and they should have called the nurse or the other way around, we will redirect the call between us, and the right professional will call the patient. Also, for nurses, it's very useful that we have an emergency telephone care protocol. So in order to treat or manage this situation, we follow this protocol plus all the information from our meetings with the plan that we make in those meetings for each child. So, for example, if a family call me when I'm on call because the child or the patient is having respiratory distress, what I will do is I will start treatment with aerosol therapy, oxygen therapy, and maybe if I think it's needed, I will recommend a secretion aspiration, and I will reevaluate that situation in half an hour. And then after half an hour, I will call the doctor. Maybe just to tell him, this happened, I treat it on this way, and just to ensure continuity of care, or to let him know or let her know, well, they called me with this situation, I did this, and he has improved, but just a little bit, or he hasn't improved at all. So in those cases, and in those cases the nurse from the beginning realized that this is a severe situation, and we, although we give some recommendation, call straight the doctor will reassess the situation, and we will determine if we have to go to the house for an urgent visit. But where do we go? We go to where the child is located. Doesn't matter if it's their own house, the school, the vacation home. The only requirement that they have is that it has to be a house within the autonomous community of Madrid. But what happens when our children go on vacation? For example, we live in Madrid, there are no beaches, and in summer, they go to the seaside. Okay, in those cases, we always program everything in advance. We ask them to let us know when they are traveling, where are they going, if it's obviously inside Spain, and which city, and the address. So we will talk with the pediatric palliative care team of that area. We will check if there is home care over there. If not, we will see which hospital, in case of emergency, is the best for that family to go, and we will let the family know. And we will also arrange all the oxygen and all these devices, because obviously there are things that are very heavy and are not safe also to travel with them. So if something happened to a child that maybe is in Alicante, what we will do is that we will, at the beginning, we tell the families that we also give them telephonic support in those emergency situations. Maybe we can sort that situation with our telephonic advice, but if not, we will recommend them to go to hospital if there's no home care. And we will contact the hospital, the doctor on call will contact the hospital, and will tell the hospital what's the situation of the child, what's his previous history, and at what point we are. And also, he will offer advice at any time they need. And if there is home care, maybe family already have the telephone, but the doctor will call them as well. So I've been saying here many times now that we provide 24-hour care 7 days a week. But I want to remark something here. As I said previously, families come from different types of care, let's say, or system. So they are not used to call us. So some problem that happens sometimes, not very often, but sometimes, is that families don't want to bother us, and they don't call us. So if the child is in pain, for example, at 3 o'clock in the morning, they will give him paracetamol or the medication that they usually give him for pain, and they will try to wait until 8 o'clock, because how are they going to call us at 3 o'clock in the morning? So this is something that really worries us, and we encourage them at every visit, please don't do this, because we are here to help you. We are here to actually care for your child during the whole day. So we sometimes tell them, what would you do if you were in hospital, if you were admitted in hospital? Would you call the nurse? If the answer is yes, you have to call us. So this is a simple sentence that I think it's clear for them. But why do we think this is useful? This is a useful tool, both telephonic consultation and video consultation. Look, this is the data from July 2023 until July 2024. In 1 year, we did 2,132 planned home visits from Monday to Friday. And we did 212 urgent visits. In between these visits, we did more than 6,000 calls between doctors and nurses. So we are pretty convinced that without these calls, our number of urgent home visits would have increased. So from our point of view, telephone and video call helps to determine when to do a home visit, allows for the early initiation of treatment, facilitate the quick resolution of care issues, which is of great importance and very valued by families and patients, provide support for families at the exact moment they need it, and again, this is very valued, and in the end, enables the home hospitalization. But telephonic consultation and video consultation, it's also very useful at end-of-life care because, as I was saying previously, promotes a close follow-up between home visits and also enhance the child comfort by treating symptoms at the exact moment they occur. But also, it's a good tool to assist families in deciding when to administer an on-demand medication or infusion bolus. Because you know what happened? Sometimes they are used to use, for example, oral morphine, but when we turn into a subcutaneous infusion of morphine, we tell us, okay, if the child has a peak of pain, you can give 1 bolus. If in 10 minutes this is not useful, the situation hasn't improved, you have to call us. Or if, for example, you need the child is in pain again, half an hour or an hour later, you have to call us again. So we have to have a control on how many bolus, obviously, and what's going on in the house. So we let them give this unique bolus by themselves. But this sometimes families feel afraid because they don't know if it's the exact moment to give the bolus. So they usually call the nurse when this happens, and the nurse assesses the situation and tell them, yes, okay, it's a right decision, give the bolus, and this is very useful. Also, for example, sometimes we use automatic subcutaneous line. If this line comes out by accident, they can also put a new one guided by video call, because previously we would have explained this in a face-to-face visit. Or if we have to modify the infusion rate, again, we can do this in a secure manner by video call, and it's another thing that we would have previously talked at home with them. So it's not the first time they are doing it when we do it by video call. But also it's very important that enables the team to support the family whenever they need it. And in case of unexpected death, or if the child passes away before the team arrives, because I was saying that we have this traveling issue, it's a useful tool to actually be with the family. Or if we go there and the child has already passed away, but when we leave the house, there is any doubt regarding the funeral home, they can still call us or call our worker, social worker on call, that is during weekends, from 8 to 18 hours. So, to summarize, I will say that 24-hour telephonic attention is essential to ensure a good home care. Thank you very much. I don't know if you have any question or comments that you would like to share. Thank you.
Hello, thank you very much for your presentation. I have one question.
I couldn't see you.
Do you hear?
Yeah.
Hi. Thank you very much. It was very good. How do you train your team? How often do you train your team for communication, for using some new medicine?
How do I check?
How do you train?
Train. Yes. Yes, we also, many of us, we do like, first of all, when someone comes into the unit, they don't go to work with patients straight, yes, because in Spain, the system works completely different as in other countries. So a nurse can come in without previous knowledge on this. So we keep her like in an induction period where she learn and train. Also, there is a master that we teach in there, so most of us are doing it or have done it before, and we do like continuous education. So this is how we do it.
Hello.
Hi.
Thank you very much.
Sorry. Thank you.
Wonderful achievement. Just actually a couple of questions, if you don't mind. The first is, what is the minimum size of a team to be effective to deliver your care? And the other question is, would it work if it was multiple small teams instead of one central team?
Well, the first question, you have to bear in mind that we are on call is one nurse and one doctor, but during the day, in our case, it will depend on the number of patients. But in our case, we need at least 4 doctors and 4 nurses, of which one of those will be on call, but will be off the following day. So I cannot give you a number because it will depend on the number of patients, but you have to bear in mind that you have to be able to actually deliver the routine care. And you cannot be on call and working, no? So you need enough people to deliver the care for the number of patients that you have. And the other question that you do, in Spain, there are, for example, another unit in Murcia that they do like this. They have like they are the same team, but they are like divided. Instead of being in the same place, I think they are like in separate areas. But at the end of the day, they have, again, this main team. So you can work as small teams, but I think it's very important to grow as professional, to be able to talk with your colleagues, to talk about advanced care plannings. These weekly meetings that we do are very, very enriching. So I think it's important to at least join the main team once a week. Thank you.
Congratulations, not only...
I don't know, where are you? Sorry.
Here.
Okay.
Congratulations, not only for your presentation, but for the work you do. And I would like to know whether, when a child is under your care in the visit, in the program, visit home program, when a child has, for example, a respiratory viral infection or other pediatric issues, are you the team in care of that problem? Or so are you the one who control the child in this situation? Or is another pediatric team that is in care of that?
No, the doctors of our unit are the reference doctors for those children. So sometimes they talk with other specialties. For example, as you said, an infection. We may treat that at home. It's okay. Sometimes they go to hospital, but not because of the infection. Sometimes because families prefer to be in the hospital rather than in the house. But if the doctor, for example, thinks that the child will beneficiate of, for example, IV antibiotics, then rather than doing that at home, we could do it. But sometimes, rather than doing that at home, depending on the situation of the child, we will transfer the child for a few days to our own ward. However, in other cases, we will have put IV antibiotics at home. But it will depend. But we are like the reference team, so the other specialties talk to the reference doctor, and they make decision in conjunction. Thank you. Okay, so thank you very much for listening.